Okay, so let's talk about these different opiates. This is going to be a little bit more content heavy and not as concept heavy, but so it should move a little bit more quickly. So, different opioids or opiates, which is what we refer to as exogenous opioids, um, can come from multiple different sources. All of the ones found here in purple are what we refer to as natural opioids. They can be found and distilled from something in nature. For example, codeine, which is found in cough syrup, thibane, and morphine are all come from opium, or comes from the poppy flower. Semi-synthetic opioids take these molecules and then modulate them. So oxycodone, which most people know is a painkiller, heroin, which a lot of people have heard about, and hydromorphone, which is also used as a painkiller medically. Right? And then you have the fully synthetic opioids. Fentanyl and methadone are the two that we're going to talk about. Fentanyl is a much more potent form of morphine that is often used as post-surgical pain care. Methadone is used as a replacement therapy for heroin or morphine addiction. And then we've already talked about the endogenous opioids that are found within your body. So let's talk a little bit about morphine. Morphine is a Schedule II drug, which means that it has a high potential for abuse, but it also has a medical use. Morphine is the standard by which all other narcotics are measured. If you have something that's a narcotic, it's going to cause sleep. So all of these drugs are going to be sedating. So think of it like as narcolepsy. So a narcotic is something that puts you to sleep. Morphine is the measure, so we'll all say, every time we refer to how potent something is, we're going to refer to it as how potent it is relative to morphine. It is also the precursor to many of the less potent semi-synthetic narcotics. It's also the precursor to many of the more potent as well. It's also a precursor to heroin. One of the huge differences between heroin and morphine is that heroin has an increased lipid solubility. This matters because of how quickly it can hit you, right? As we know, an increased lipid solubility means that it can pass through membranes more quickly. The more quickly a substance can reach your brain, the more sudden the onset of the high, which means it's usually more reinforcing, okay? So the chemical differences between morphine and heroin is what's going to instill that increased solubility. Heroin is usually produced in a powder form and if you take it orally, if you just swallowed a pill of heroin, it'll be metabolized to morphine. So it's not taken orally often because most people who are taking heroin want that fast onset, which will not come if it's being metabolized to morphine first. Black tar heroin is a different preparation of heroin, and it is less pure than powdered heroin. It's usually mixed with other things. Heroin is a Schedule I drug, meaning it has high potential abuse and no medical use. It is not used at all in medical context. It has been in the past, but not anymore. Fentanyl is also Schedule II, similar to morphine. It is 80 times more potent than morphine. It is typically used for anesthesia, either IV. It can also be used transdermally in a patch like this. A transdermal patch can often release a drug at a steady rate for an extended period of time, which can be very helpful for something like surgery recovery. You can also get fentanyl lollipop for breakthrough cancer pain, meaning that cancer pain that sort of spikes above the ability of other painkillers to manage it. So this is a representation of the lethal amount of heroin versus the lethal amount of fentanyl. As you can see, it would be much easier to overdose on fentanyl than on heroin. Heroin laced with fentanyl is a large cause of many of the heroin overdoses that we see. Okay. So this sort of gives you we've seen this before back when we talked about potency and efficacy, but this sort of gives you an idea of how different opioids relate to each other. So hydromorphine is going to be similar to oxycodone, and it is a medicinally used painkiller, usually given in a pill form. Its ED50 is much smaller than morphine's, so we know it is much more potent. Codeine, which is found in that cough syrup, is going to be less potent than morphine and hydromorphine. And as you can see, especially when it comes to pain threshold, aspirin is a lot less efficacious than any of these opioids. So that sort of should reflect what we expect from this class. So a couple more opioids which are just a little interesting and weird. One is desomorphine. Desomorphine is also known as crocodile. It can be referred to as a zombie drug. Its first reported use is in Russia, and it's most common in Russia and Eastern Europe. It is a derivative of codeine. It is a cheaper heroin replacement. It is usually given through IV injection. It immediately causes vein damage to the veins, which causes infections. Those infections cause the skin to become hardened and discolored, and it makes their skin look like a crocodile, which is where it gets its name, crocodile. It is made from codeine plus other organic solvents such as gasoline, paint thinner, lighter fluid, hydrochloric acid, and red phosphorus, which is what makes those red tips on matches. It takes about 45 minutes to make, and it takes minimal equipment, but it is wildly dangerous. It is a very fast and short high, so it's going to be highly reinforcing, but the health effects of it are more immediate and drastic than we see with other opioids. So opioids are usually used as analgesics, as a relief of acute, postoperative, or chronic long-term pain. There's actually a big debate in the chronic pain field right now about the appropriate use of opioids and how chronic pain patients who need those opioids are going to be able to have access to them if we have a strict lockdown on the prescription of opiates. It can be used as a narcotic to cause sleep. This is not recommended because anything that you're using to cause sleep is already going to be habit forming, and using an opioid is going to sort of heighten that reinforcement. Additionally, if you're using it to sleep, it may be easier to take a overdose, which can cause respiratory depression. It's also used as a cough suppressant. It is very effective as an antitussive. It is also used as an antidiarrheal. One of the main side effects you'll consistently hear about with opioids is constipation. There are a high expression of opioid receptors in the GI tract. You can get something that is similar to an opioid that will activate those opioid receptors in the GI tract over the counter called loperamide. Looks like this. It's also known as Imodium. It's an antidiarrheal. It can barely cross the blood-brain barrier, so we do not consider it's psychoactive, right? It's only acting on the peripheral nervous system to control the peristalsis in your GI. Recently, there has been spikes in cases of loperamide overdose, meaning that somebody is taking 25 to 50 times the recommended dose. At these doses, you do get some drug able to pass the blood-brain barrier. People report that they're doing this in order to replace a high or avoid withdrawal because you can access this drug over the counter. So there was a huge increase in calls related to intentional loperamide exposure from 2011 to 2014. This is differentiating from, let's say, kids or toddlers who accidentally took way too much of this drug. So the overdose can lead to significant central nervous system or respiratory depression. Respiratory depression is which remember means a decrease in your ability to breathe, is going to be the main cause of most opioid overdoses. And that's usually what's going to be fatal for people when they're experiencing an overdose. Cardiac dysrhythmias, so an irregular heartbeat, urinary retention, holding in all of your urine, paralytic ileus, basically your small intestine stops passing any material on. This can cause blockages within your colon, and which can be absolutely fatal and usually require surgery to resolve, which can also lead to death. Okay, so the acute drug effects that we usually see with opiates are constricted pupils and itchy skin. These very small pinpoint pupils will never go away. We do not develop a tolerance to it. It lowers blood pressure. It's causing a dilation of the periphery blood vessels, so you can get flushing and sweating. It slows peristalsis, so those movement of the autonomic nervous of the muscles in your GI tract, which is going to cause the constipation we discussed, and bowel blockages that are going to lead to many of the hospital stays that we see with people who have an opioid problem. You're also going to see a reduced sex drive and fertility. There's a significant drop in the levels of sex hormones in people who are chronic opioid users. So it is more difficult to conceive if you have a history of chronic opioid use. Okay. Effects are both dose and absorption dependent. I mentioned absorption dependent because remember, so one of the differences between heroin and morphine is the ability to get into the drug stream, which is absorption. So that absorption difference is going to be pretty important. So that is the different opioids and how they're used. Next, we're going to talk about the pharmacokinetics and how that influences tolerance.